When you are suctioning, when you're inserting the suction catheter, do you suction on the way down? Do you suction on the way up? And the deal is you suction for no more than 10 or less seconds each time. And you twist that catheter coming out. Remember, it's a sterile procedure. That's why I say if you have to pass the catheter more than one time, you don't auscultate until you're done. All right? Because you've got sterile gloves on. If you pass the catheter suction and then you listen with your stethoscope, you've just contaminated your glove. Right? So you listen until when you're done with all your suctioning attempts. You do not suction for a total of more than 30 seconds. So if each suction attempt is 10 seconds, then you can only suction for 3 times. Okay? No more than 30 seconds. All right. Let's talk about mechanical ventilations while we're on the subject of all of this marvelous stuff. Okay. Somebody who's on a respirator, a mechanical ventilator, you need to assess that person's respiratory status frequently. Remember, he can't tell you whether he's short of breath or not. And you essentially may not be able to tell because if he's being assisted totally by the ventilator, you don't know. Okay, so it's your job to assess that respiratory status. Blood gas values need to be monitored frequently because he's on a ventilator. And you need to know, is he acidotic, is he alkalotic, do we have to adjust the settings? Okay, it's your job as a nurse to do all of this monitoring. I mean, if he's alkalotic, you've got to tell the doctor so that he can help, he can give you the orders, whether to up the IMV, lower it, to change the FiO2. I mean, this is something that is your job as a nurse. You gather the information and you pass it on to the doctor. You cannot change the IMV on your own, but you need to tell the doctor. It's your job to pass the information on. You've got to also make sure that he has adequate nutrition and fluid therapy. Remember yesterday we talked about enteral nutrition, and I said people who are critically ill, you will see sometimes them being on some form of enteral nutrition. Well, if they're on a mechanical ventilator for extended periods of time, you're going to see them getting some form of enteral nutrition. Okay? You've also got to remember, and this is Grace's rule of thumb, okay? It's not just mine. I think it's every single nurse in the world. You've got to remember that if a person is on a mechanical ventilator, whenever you're in doubt, bag him with 100% oxygen. When you are in doubt, bag him with 100% oxygen. In other words, alarm goes off, you go to check, you cannot figure out what in the world is going on. You know what? Bag him. Take that bag valve mask, put it on, the trach, or the ET tube, and just give him 100% oxygen. It's never going to hurt him. Okay, so whenever you're in doubt, go ahead and do that. All right, let's talk about high-pressure alarms and low-pressure alarms. High-pressure alarms, what does that mean? It means that the machine is meeting some obstruction, it's having some difficulty administering the oxygen that it wants to administer. So it's meeting a resistance, so it has to use a lot of pressure, okay, to deliver it. So a high-pressure alarm generally means there's some form of obstruction, whether it's partial or complete. When you hear the high-pressure alarm going off, here's what you've got to do. Number one, look at the patient, because maybe he's full. In other words, maybe he's got lots of secretions. Okay, so auscultate the patient. Okay, look at the patient. Maybe he's full. The other thing you want to do is to look at that corrugated tubing, that connects the machine, that humidifies the air that goes in. Look at that corrugated tubing because that could be full of water. And if that's full of water, you just dump the water out, and that could take care of that. So generally, a high-pressure alarm means there's a partial or full obstruction. So you want to check the corrugated tubing, and you check the patient. He could be full, or he could be doing one of these gagging numbers. Have you ever seen that? Where he's actually bucking the placement of the tube, so he's gagging. All right, and that in itself can cause difficulty for the machine because when you gag, you constrict your muscles here. Okay, and that could be causing difficulty to the machine to administer the oxygen that it wants to deliver. Okay. A low-pressure alarm is pretty simple. A low-pressure alarm means it's too easy. The machine is finding it way too easy to administer the oxygen. Usually with a low pressure alarm, there's some form of leak or some form of disconnection. Low pressure alarm, first thing you do is check all your connections, make sure it's hooked up to the patient, make sure all the connections are hooked up. Low pressure alarm, generally a leak or there's some form of disconnection. Okay? An apnea alarm. An apnea alarm is when there's a very low respiratory rate. And that apnea alarms or periods of apnea usually occur when you're attempting to wean a patient off the ventilator. Okay? Any questions so far? Oxygen alarm simply means that you're not getting enough oxygen. We've done this. All right, let's talk about some respiratory medications. We'll talk about theophylline, we'll talk about Alupent, and I was asked a question yesterday off the air, offline. I was asked a question, which one do you give first, with the MDI inhaler? Do you give the anti-inflammatory first, or do you give the actual medication first, the beta blocker first? Well, what's the answer to that one? You give the anti-inflammatory first, obviously, because what do you want to do? Yeah, you want to open up the passageway so that the beta blocker can get in. Okay? So the anti-inflammatory can be something as simple as a steroid. Okay. All right. Theophylline is that tried and true drug. Theophylline is the name of the drug that you give PO. Aminophylline is the name of the drug that you give IV. Same drug, just that theophylline is PO, aminophylline is IV. Theophylline, which is a xanthine derivative, along with aminophylline, these xanthine derivatives relax smooth muscles of the bronchi. Okay, you can give this theophylline either by mouth or by rectum, but you need to monitor levels. We're tending to get away from theophylline because it's a troublesome drug, because you've got to monitor levels, and also because of the side effects of theophylline. The side effects of theophylline include things like nausea and vomiting, rapid heart rate, anxiety. I remember my daughter was 5 years old, and she's diagnosed with asthmatic bronchitis, and they put her on theophylline. And I remember her coming to me one day, and she looked at me with big old tears in her eyes, and she said, "Mommy, my heart hurts." Okay, and that was because she had such severe palpitations from the theophylline. It's a difficult drug to manage because you've got to keep drawing levels on it, okay, to make sure that it's within therapeutic range. And the therapeutic range is between 10 and 20. I think it's nanograms or something like that per deciliter. But you've got to monitor theophylline. Side effects, like I said, tachycardia, nausea, vomiting. That was another thing she used to do, is throw up all over the place. Okay. Alupent is another drug, and Alupent actually relieves the bronchospasm, and it's given by mouth, or it can be given through an MDI, a multi-dose inhaler. Proventil. Proventil relaxes the smooth muscles of the tracheobronchial tree. So you give your Proventil, and then you give your Alupent. We're moving right along, folks. We're going to do the GI system now. There are 6 tests that we're going to cover. Okay, 6 tests and 6 definitions. Okay, let's talk about the endoscopy. Okay, and the endoscopy is also known as the esophago-gastro-duodenoscopy, which is a mouthful, yes. But I like the long one. You know why? It's also known as the EGD. The reason I like it is because it tells you exactly where you're going and exactly what you're looking at. Yes? Esophago, so you're looking at the esophagus. Gastro, you're looking at the stomach. Duodenoscopy, you're looking at the duodenum. Wow, voila, it's right there for you. Yes, isn't that wonderful? So the purpose of this EGD is to observe and to see if there are any ulcers or inflammations or tumors in the esophagus, in the gastric cavity, or in the duodenum. Now, how nice is that? Well, your nursing intervention, what is it? What is your responsibility as a nurse? Your responsibility as a nurse is to understand what this procedure is. You're not doing it, so you're not getting the consent, need a consent for this. You're not performing the procedure, so you don't get the consent ever, right? You just witness it. We're not asking you to know the procedure so you can perform it. We're asking you to know the procedure so that you know how to teach the patient and what to tell the patient in terms of problems afterwards. So you want to tell him he has to be NPO for at least 6 to 8 hours before. And why is that? We're going in to look at the stomach and the intestines. If he eats, we're not going to be able to see the stomach. We're going to see lots of food, lots of chyme, actually. All right? So NPO is 6 to 8 hours before. Tell him that after the test is done, okay, we're going to numb his throat. Yes, we'll help him. We will numb his throat. So after the test is done, he will not be able to eat or drink immediately, but we do have to check for a gag reflex to return. Don't you love that little gag reflex thing? Yeah, we'll check for his gag reflex to return. And if you think about what I said, every time I have said that there's a procedure done, you know, whether it's if it's an outpatient procedure and you're going down the throat, you need to check for gag reflex afterwards. Check for your gag reflex afterwards. Check for any dysphagia, difficulty swallowing. Check for any bleeding, because those are complications that could arise. And it's up to the doctor to tell him this is what might happen. Okay? It's very interesting. Have you ever sat in and listened to a doctor describe a procedure? We may puncture your lung, we may puncture your liver, we may kill you, but sign right here, please. You know, we do that. The other thing also you can tell him is that if he does have a sore throat, which he probably will have, once his gag reflex returns, we will be giving him warm saline gargles. We do avoid giving narcotics for this procedure because it does go away very quickly, the pain. Okay, the upper GI series is the barium swallow. This is the second procedure we're going to talk about. The barium swallow is that wonderful stuff that you swallow and you drink, and he drinks it under fluoroscopy, so you have to take him to a special procedures room. He's given this barium to swallow, and he drinks it, and they just observe it as it goes down. Okay? The purpose of a barium swallow is to determine and to see if there are any abnormal structures, any abnormalities in the stomach, and also to observe the emptying time of the stomach. Another thing we can look for is an ulcer. It may be possible that you can see an ulcer. Your nursing care, nothing by mouth after midnight. Why? We want that stomach to be empty, because when he swallows that barium, we want to see the full outline, the full contour of that gastric cavity. If he's got food in it, then guess what? You're not going to see the full contour, right? So NPO after midnight. Tell him he's going to drink this very delicious, yummy solution of barium. And yes, you lied. And you can tell him afterwards, I lied, sorry. No. It's really awful tasting, but it's getting better now. I mean, years ago it was very chalky. Okay, now it's not quite as chalky, but it's still nasty. He will be drinking this aqueous suspension of barium. You also want to tell him preoperatively and then remind him postoperatively that when he goes to the bathroom, you want to see it. In other words, do not flush the toilet, let me see it. Okay? If by any chance he does flush the toilet, what can you do? Ask him, what color was your stool? If it was white, you go, oh, good. That means he's passing the barium out. It's really, really important that you do this, because if you do not observe, if he doesn't pass out that barium and it stays within him, barium turns into rock solid, stone. Yep. So if you don't ensure that the barium comes out, he will end up with a rock in his intestine. And that will not be nice. The lower GI series is the barium enema. Again, anytime we're doing any of these procedures, what are we doing? Why are we doing it? For fun? No, we're not doing this for grins. We're doing this because we want to see if there are any abnormalities. If you think about the barium enema, it means we're going up the colon, right? So if we're going up the colon, then what are we looking for? We're looking for any abnormalities within the colon, within the cecum, and possibly the appendix. So it's the lower GI tract, so it's the large intestine we're looking at. You see, if you can rationalize this out if you think of it that way. It's the lower GI series, so you know your anatomy is that there's a colon, the cecum and the colon, right? And right by that ileocecal valve is where the appendix is. So you know you're looking at the colon, the cecum, and the appendix. Do you see? That's why I said it's important that you understand the anatomy. So what are your objectives? What are your nursing objectives if you're taking care of a patient with a lower GI series? Well, you're going to give laxatives, okay? This is before. You're going to give laxatives and soap salt enemas until clear. So you will give him this wonderful